All right, welcome everybody. Happy Wednesday to you all. Welcome to June's AHA team training webinar on engaging physicians in teamwork training for quality and safety, or why don't your physicians get engaged? I think that's a big question. So we'll get going here in a minute. A couple housekeeping items that I wanted to walk you through. First of all, my name is Mithu Patel. I will be your moderator for this session. I'm honored to be here. A couple rules of engagement. There's a couple ways you can access your audio. So if it's a little clicky on your computer or you don't have a weak connection, you can always dial in through your phone for a better audio connection if you prefer it that way. We will have some time for Q&A. If you haven't already submitted your question, please use the chat feature to submit any questions that you might think of as we go through the presentation. And we'll have some time at the end to go through as many questions as we can. A couple other items regarding Zoom to enhance your experience. This will be recorded and shared, so if you miss something, we'll have that for you. And please use the chat feature to your advantage. You can chat individuals or the entire group. And again, that's the best way to get questions over to us. A couple other items of note. If you want to, if you're doing this for continuing education credit on the next page here, we do have some information for you. You have to create a Duke one link account. You only have to do that once. So if you have that set up already, you're all set. You have to text that code that we have in red listed in the next 24 hours to get your credit. If you miss it again, we'll flash the screen again at the end of the presentation, but just wanted to make sure you guys were aware of that. A couple comments, just so you're aware on upcoming events that we have on the next page here. We're excited to get back to in-person training events, courses, and workshops. We have one at Duke at the end of September, and then a few weeks later, we have one at Northwell. So a great way to get your master trainers trained up on master training if you need a refresher. Another great way to do that. So we're excited to offer up our in-person courses again. And then, of course, we have those webinars listed, another one later in June, and then a couple there throughout the summer. So hopefully you guys can continue to join us in this format, in this stage here. All right, let's get to the good stuff. I'd like to introduce our presenter and leader for today. Dr. Kevin Crane joins us from Tulane University of Medicine, where he's the professor of medicine, the vice dean of academic affairs, and also the director of team training. Kevin is a strategic and really important partner of the AHA team training team as well, a thought leader that he helps guide our areas of focus, where we should prioritize, where we need to take team training to continue to be relevant in healthcare today. So we're very honored to have Dr. Kevin Crane with us today. So all yours, Kevin. Thank you so much.
Okay, thank you for the very nice introduction. And I'm also really just delighted to be here. And like all things, I hope this will be fun for people and useful. And let's talk about what the objectives are going to be for today. So first of all, we want to know what is it we can do to help physicians get engaged. So we are going to talk about barriers to physician engagement. And I'm going to, as a means of doing that, describe literature-based strategies that have been suggested to improve physician engagement. So you should be able to describe them when you're finished. And then, of course, what we want to do is go forth and utilize methods that we'll talk about to actively engage physicians in team training for patient safety. And the real goal of all of this, and the reason I enjoy working with my colleagues at the American Hospital Association and the other colleagues I have at the other team training centers, are really focused on improving outcomes for patients through better patient safety. So that's where our focus is going to be for the day. So what I'd like to do is begin by getting some background information about our audience. So the first question we really like to know is, who is on this call? And we put up a poll, not very difficult, and we'll give you a little bit of time to respond, and we'll show you the responses. Well, here we go. What a big surprise. We're doing a presentation on why physicians aren't engaged, and only 3% of our participants, according to this poll, are physicians. So we have the issue really highlighted for us. And as we might expect, significant number of nurses, quality improvement and patient safety officers, as well as those coming from other backgrounds as well. So let's go a little bit further now that we can clearly address that. And what I'd like to know is, why do you think your physicians are not getting engaged in patient safety or team training activities? And again, we're going to give you the poll. Just provide what you think is the best answer. And I'll let you just choose what you think is the best answer of the ones shown for your purposes. And maybe not a big surprise, the most common answer was that physicians are too busy providing patient care. There's some concerns about lack of compensation for time spent in patient safety activities, as well as they think that they're doing well enough already. And then we have a variety of other answers. So again, the issue of time is a huge, huge issue for not just physicians, but for all of us in patient safety activities. So thinking strategically is very important. So let's move forward and look at this and have a discussion about this. So first of all, why am I addressing engaging physicians? Well, as somebody who's been practicing almost 40 years, I'm in the trenches at times, and every day I see patient safety issues, typically resolved around communication. And it's important to realize that everybody is trying to do their best. So in some degrees, I feel I have a personal mission to help with patient safety, but I've also been involved with the team training process along with many of the other centers for many years. And this is a common question and a common problem that we're given on a regular basis. So what is the goal in engaging physicians? Well, you have to be really specific. The goal in engaging physicians is to improve patient safety and develop better outcomes for patients. So you want to be very, very specific with physicians in addressing the issue of our goal is focused on patients and improving the outcomes. And finally, why is physician engagement so important in doing so? Well, again, we're going to look at the literature, but without physician engagement, it's very difficult to be able to move your processes forward in a consistent and effective manner. So the goal is patient safety, and the outcome that we're looking for are better patient outcomes, whatever you're going to measure, and having physicians directly involved is a key part of that. So let's look at some recent literature on this topic. There are a number of people who've done some very thoughtful reviews in this, and I think it adds to our understanding. So first of all, what is the framework that we want to use for engaging physicians? So Tates and colleagues from Harvard about 10 years ago put together a nice framework for engaging physicians, and they provided a very specific definition of physician engagement in quality improvement, which is the involvement at every step in the process of working to reduce unjustifiable variation in care and improving patient outcomes while considering the process and systems in which patients receive care. And as you can see, I want to highlight two very, very important things. One is variation in care is normal, but unjustifiable variation in care may lead to significant issues with quality improvement and patient safety. Similarly, the processes and systems that we use need to be consistent, and you need to have physicians involved in participating in these processes and systems for there to be meaningful quality improvement. So the definition that is shown here is one that has been consistently used. Now, in their review, what they did is something very interesting. They did a survey of 10 high-performing hospitals in the US to determine how they were going to engage their physicians in quality. And the hospitals that they chose came from the 2010 US News and World Report, Leapfrog Group, and I'm going to show them to you in a minute. I think that most people would agree these are the hospitals we think of when we think of some of the best hospitals or systems in the country. This was a qualitative study. They used site visits and semi-structured reviews with 20 questions, and they interviewed a variety of quality leaders, including the different positions as shown below. So what they wanted to do is understand what is physician engagement and why is it so important. So we provided the definition just a minute ago, but in terms of physicians themselves, if they're going to be the ones who have optimal ways of delivering healthcare, you want it to be focused, smooth, and effective, and you want to achieve certain specific patient outcomes, and you want to be able to measure them and demonstrate that's the case. The leader said without engagement in the line of physicians, there is no meaningful way to influence the variation in healthcare delivery. And we all know that variation in healthcare delivery is a significant problem and does lead to problems with outcomes and issues related to patient safety. So how did they go about this process? Well, here are the institutions that they reviewed. And as you can see, this is a very strong group of institutions that have systems that are designed to improve quality and safety. And again, remember, we're talking 10 years ago. So now other institutions have joined in this group. But these are large hospitals. All but one was a teaching hospital. Physicians were salaried in most of them. And you can see that the rankings are shown, the leapfrog groups are shown. So this is a large group of hospitals, both including several children's hospitals as well. And then what they did was they conducted interviews of a variety of the leaders. 42 interviews were conducted altogether. Most of the interviews were conducted with physicians, but it also included leaders in the institutions, vice presidents, CMO, chief executive, patient safety leaders, quality officers. So they ended up with their 46 interviews. And let's look at exactly what they did find. So as we talked about, understanding the barriers to physician engagement is particularly important. And I'm going to show you the frequency of what they found. So as you might suspect, the number one barrier was lack of time, which is what in our poll we have subsequently found. So almost half of the reporters thought this was a significant problem, but some of the others are also important. So institutional culture did not always support physician engagement, another significant problem, a major barrier to physician involvement. Physicians have a desire for autonomy, so we do see variations of care, but again, what we want to do is reduce unjustifiable variations of care. Lack of medical school training, and this is really lack of medical training in quality improvement and patient safety. So whether this is medical school training, residency training, physicians do not always feel prepared for a significant role in improving patient safety. Trust in data, another, again, 15% of the people, but this is something to consider when you're wondering why don't physicians get involved. And most people certainly do feel that data from their own institution may be better. And too often we've heard the comment, well, that study was done elsewhere and those patients aren't like my patients. So coming up with data that physicians will trust is another important piece. Lack of information systems that will get that data is another piece of the equation. And again, we're still talking about 10 years ago. Systems have improved from there. And then, as I mentioned, the lack of actual quality improvement skills for physicians can be another significant problem in whether physicians are able to become engaged and participate in the process. So they came up with 6 different frameworks or steps in the process for being able to engage physicians. And the first one, in speaking through their qualitative interviews, the one that seemed to be the most important was engaged leadership. So as I'm discussing this, what I would ask is think about your own institutions and your own settings. Is the leadership of the institution that you're at completely engaged and will support the physicians and others in activities that are aimed at quality improvement and patient safety? Second of all, related to that, there has to be a compact with the physician where the focus is on the patient, not administrative activities, but really, are we doing something that's better for the patient? So there has to be essentially a dynamic and a reciprocal agreement where the expectations of what the organization is trying to do and what physicians are trying to do line up. So there's a shared mental model that's consistent between the physicians and the organization. And compensation does come about because quality is not an add-on and is a significant problem, and asking physicians or any other healthcare workers, especially in the current environment, to do more and more is a significant problem. And when you do so, you're risking that you will not get really full commitment of the people involved. And compensation doesn't mean you're paying people exact amounts for specific hours, but there has to be some way of recognizing the time and effort that people contribute to do so, so that it does become a priority and not just an add-on. So to do that, one of the steps was to have some type of realignment of financial incentives. Monetary rewards are important. And again, how that's structured, how it's done, but it can't be just we're asking you to do more in a very busy environment. And particularly as we know from COVID, where burnout is an issue and putting more burden on physicians and other healthcare workers is a significant problem without recognizing that. I already mentioned the importance of data. So having data from institutions that are peer institutions is really important. As stated here, there's no greater force than peer pressure in a structured format. So providing real data, comparing different physicians, different institutions that people see as peer institutions can be particularly important. And as I mentioned earlier, it's equally as important that the data is trusted by the physicians so that there's transparency of where the data comes, and the data is available both not only to physicians, but as to patients as well. So the reporting structure is important. And particularly for physicians in academic settings and academic centers, opportunities for academic promotion through their activities with quality improvement and patient safety may be very important. And sometimes that gets overlooked by the promotion committees that are evaluating for faculty. And if you think about many junior faculty who are very, very good clinicians, very busy, and do get involved in these activities, giving them opportunities for academic promotion or giving them at least credit towards their academic promotions through these activities can be particularly important. So this begins to create a framework for what are the things that we can do to engage physicians. More recently, last year, there was another quality improvement review that was performed by a group from North Carolina, from both Chapel Hill and Durham, who looked at a database from PubMed in 2019. They did a systematic review and a meta-analysis that reviewed articles for physician engagement and quality improvement. And as many of these reviews, they started with a large number, 425 articles, but only 16 were included in the final review. And an example of the types of articles, just to give you a sense, was an article from Keck School of Medicine where they looked at how length of stay was reduced and how was physician involvement in the quality improvement process utilized to actually do that. So they went into the details of the article, which I'll show you here. And as you'll see, this took a lot of work. So what they did was there were 4 days of training that provided both the resources and time for doctors to participate, two of the things that are important barriers. They learned about building cases for quality and lean thinking with tools for problem statement and for changing practice management. So again, a significant commitment from the leadership addressing barriers that typically impede physician engagement. Physicians learned which may seem very obvious to those of you who are quality improvement people, but things that are typically not part of traditional training, fish bones, root cause analysis, and application to real scenarios. And they provided training and coaching for 10 months. And many of you are thinking, wow, that's a significant commitment. But obviously they were committed. And when you think about how important reducing length of stay is for most institutions, thinking about the financial rewards, that may also be particularly important. And how did they get people to get involved? Well, they worked with the early adapters. So they rolled this out by bringing this information forth, and they looked to the chairs who raised their hand first, pretty simple approach, and took the early adapters as those who are interested in getting involved in this process. And we will talk a little more about the importance of finding those physicians who really do want to get involved and utilizing them as your leaders in this process. If we look at some of the other things that were done, they took several from the scope and review. They came up with several phases in terms of ways to engage physician. And you'll see a lot of overlap between what was talked about in the earlier study and what is being discussed from this review, from the 16 studies they included. And the first part was engaged and supportive senior leadership. Again, common theme, going to be repeated. And the reason it's repeated is it's that important. So you want to be sure that your senior leadership is working directly with the physicians where there's a clear vision, everyone's on the same page, and the physicians are clearly supported and feel that the institution has made a effort to move in a direction that will support them regardless of what they do, okay? And then knowing what the barriers are, you have to support the physicians if you're going to be successful in those projects. So the organizational goals need to be very clear. And part of those organizational goals need to be very specific about what outcomes the projects and activities are really focused on. So the data needs to be clear and transparent. We've repeated again several times the importance of providing QI education and training for those who are interested in doing so. And there are those who are interested given the additional training, but at the same time, knowing that the time constraints are significant, you have to provide time. So again, supporting physicians in a variety of ways with time, training, and tools that will help them do it, which is providing with data, and consistent with the organization and consistent with leadership, all going down the pathway in the same way. And then finally, you have to be able to sustain this process. So it's not just about doing initial projects. What we're really trying to do is change eventually a culture, which is a long-term process. So you have to recognize improvement success. You have to provide rewards for those who can do it, such as promotion. And finally, recognizing, again, the time constraints that occur over time and supporting physicians so that these activities can be sustained over an extended period of time. So what are the lessons for institutions in general, coming from literature and coming from other reports along this? So again, number one is starting with an engaged leadership from the C-suite leading directly to physicians so that it's very clear what the institutional goals are, that the institutional goals are supported. So you really want to have leaders with street cred that are able to get MDs to buy into quality and safety, that communicates a clear institutional mandate for QI. Almost every institution talks about the importance of what to do, but it's very, very important that the leaders demonstrate their commitment by walking the walk and making sure they're actively involved and are role modeling this type of activity. Similarly, it's equally as important to have physicians, many of whom are in this role as chief medical officers, where physicians can listen to their peers and be directly engaged in the quality improvement process and feel that they're part of the process with other colleagues. It's, again, emphasizing that resources for physicians, if you want them to participate in this process, are very important. Time and money certainly part of it, but also, as we keep saying, training and giving physicians the tools to do so um, are equally as important in looking for success with physician engagement. So this includes time and knowledge, as I mentioned earlier. The other piece that also is particularly important is to have a multidisciplinary and collaborative approach. Certainly, medicine has become a team sport, and in providing education for staff, you really want your entire team to be trained, and you want your team to be trained at the same time. So putting the project in perspective, looking at the personnel who need to be trained, you want everybody in the room at the same time, learning the same thing, and recognizing that there's support among each other so that you have a system of mutual support for whatever your projects or your interventions may be. And this may require quality contracts, but again, part of this goal is working on a team training process where the physician can play a significant role and work with colleagues from other healthcare professions who are part of the process. And you also want your policies to be evidence-based. So there is a significant amount of literature that has been developing over the last 10 years, particularly showing how team training, team steps can be used to improve outcomes. So it's no longer showing that systems seem to be better. We can demonstrate significant improvements in a variety of ways through the literature. And particularly if you can provide literature for physicians in examples in systems that are similar to your working, can be even more beneficial. So again, clear direction set with the senior leadership. And you do want a physician champion. We'll talk a little more about this, but physician champions are everywhere. Physicians want to see good outcomes for their patients. They want their patients to do well. And so the lack of physician engagement is not that they don't care about this, but the problem are all the different barriers that I've mentioned earlier. So understanding those barriers and making it easier, especially if you find specific physician champions, is particularly important and necessary for success. So things to do when you're looking at this in terms of projects and activities, if you're going to invest in activities, use evidence-based practiced activities, as I mentioned. One example is the use of bundles, for example, in central line insertions. Everybody's worried about central line infections. Everybody agrees we'd like to reduce them. There are some people who don't believe you can get down to zero, and there's quite a few places that have demonstrated that that is possible. But again, presenting evidence-based data on using, and I'm just using the central line insertion bundle as an example of what people must perform and getting physicians who are actively involved in central line placement as part of your processes. So you can talk about what must be done to reduce the infection. And again, providing the literature, here is the reference from the article that was published over 10 years ago of multiple hospitals across the state of Michigan dramatically reducing the numbers of central line infections. And part of the reason, as a number of other publications have done, are using examples where hospitals of small, large, rural, inner city are all used at the same time to demonstrate that the use of best practices and evidence-based care does lead to better outcomes. And that provides, again, more strength for your discussion with physicians in terms of using different methods for improving patient safety and improving quality. So what I'd also like to do is talk a little bit about some, as I like to put it, more observational comments from the reference articles. So there's again, a number of articles. I think I've given you two of what I think are some of the better articles more recently published related to engagement of physicians coming from multiple sources, but others have written as well. And they point out several things. One is physicians are competitive. In fact, healthcare providers in general and healthcare workers can be, but sometimes that can be used to your advantage. So providing peer data, as I've shown, in terms of outcomes. Many people who think they're doing a good job, in fact, they think they're doing a wonderful job until they see data from peers that they potentially could even do a better job in terms of patient outcomes. Physicians expect to see data to support decisions to improve quality improvement, which is very appropriate. And they have a lot of confidence in the validity of data if it supports their opinion. Now, one way of looking at that is that if you use data from your own institution, there is also more confidence in doing that. So any interventions that you follow for improving quality improvement, again, it's very, very important to measure outcomes within your institution, which can be very helpful in providing data for physicians to give them more reason to become engaged. Okay? It's also been observed that physicians are trained to be sort of egocentric first, and that is a institutional effort among all of us in terms of moving people away to more interprofessional education, to team training. And so it's really rephrasing how many physicians approach things, though as many of us have learned from our training, the more and more we train, the more and more we realize just how important having an important and supportive team around us is. And physicians aren't engaged by projects that focus on costs and waste. What physicians really want to see are projects that improve outcomes of their patients or that make their life easier at the same time by improving outcomes of their patients. So when you're looking at projects to engage physicians, reframe that question so that it's focused on patient outcomes and that it's focused on exceptional care, and it's not working on the inefficiencies in the system that really will annoy physicians and really annoy anyone who's involved in healthcare. Okay. So physicians do want the best for their patients. So what are the common concerns about engaging? Well, we've all seen this. Too much flavor of the month. For many of us who've practiced for many years, we've seen many changes over time. And the real question is there evidence that the changes that have been implemented result in an improved outcome? If you can demonstrate an improved outcome, then you're going to have your physicians on board. If you have activities where there is no evidence of improved outcome and there's more work, which is something all of us have seen over time, then you're going to lose the confidence of the physicians in the administration for presenting these types of issues. You lose credibility, and also it becomes a burnout issue. More time and effort is spent on a project without really seeing an improved benefit. All of these are activities that are improved with team training, where really the goal is to get input from everybody so that you're not coming up with projects that are not going to come up with improved outcomes. And the goal is really to work together as a team for everybody. But this is a significant problem. And what physicians really want to know is it going to take more time? We've talked several times about the number one issue is the time issue in physicians getting involved. So expecting physicians to participate in activities that take more time is a real concern, because what they really want to know, what's in it for my patients, and what's in it for me? Will it make things easier for me? Now, we're not always talking about, I want to emphasize, dramatic life or death activities. Sometimes it's as simple as my outpatient clinic works more efficiently. Patients come through the system more effectively. We finish sooner. Results are addressed when there are problems. Prescriptions are filled more promptly. All of these things in terms of doing projects demonstrate activities where there's something in it for the patients that will also result in a better work environment for the physician and actually for everybody in that healthcare setting. So all of these are important as terms of part of the processes. Okay. So what sort of recommendations can we make based on some of these observational comments and some of the literature that's been published? Okay. Well, one of the things that's particularly important is to really think strategically. A lot of these activities are really about changing behavior. So this is really about organizational behavior that's tied to medical changes. So the most important thing behind this is to think about it from a physician perspective, think about the physician barriers and why they're not being involved. And really what you want to do is use the change principles that come from the business world. Now, I can assure you that I have not had business training. I've been involved in team training. So I want to keep things very, very simple. And one of the team steps principles that has traditionally been used is to look at Cotter's principles, which are shown here. There's 8 changes that can be made. And really the first thing is there a burning platform in terms of beginning the process? So let's say you have a project or you have a problem or something in your institution where you're really trying to address an issue and you want your physicians engaged. Do you have something that they really will rally around? Is it a pet project that they're going to look at and think, oh, more time, more effort, I don't know what I'm going to get out of it, don't know what my patients will get out of it? Or is it something where you can say, you know, we're having a problem getting the labs from the outpatient setting into the OR so that everybody has the right information at the right time with the right studies and our patients are going to get the best care. That might be something that everybody would rally around. Regardless of what it is, you want to see what it is that's really going to get the interest of people because they're going to see a measurable outcome in patients, which is going to support the time that may be necessary to do these activities. So there are a set of recommendations that begin with the burning platform. I'm not going to go through all of them, but they do include basic principles such as having a good guiding team, having the right people providing information and input into the project, particularly people who understand exactly how things work on the day-to-day basis, and then moving forward and demonstrating that you can make changes using data, celebrating those wins, and eventually, over time, moving to a process where you actually do change the culture. Okay? So in terms of doing anything, you know, one of the recommendations that I would certainly make is if you're looking to engage physicians and you've got a project and you've got a concern, start with something small. Start with small changes in an area where people can really rally around and something that you're pretty certain that if you can get the team together with your physician champion, that you'll have a definite win, something that's obvious to others in the organization and something that will draw people forward. Don't try to start with a very large project that's complex, that makes difficult for everybody. Second of all, you really have to have a physician champions. So you have to find them and use them. Typically, these are the people who will be the early adapters. They may be, generally speaking, some of the newer physicians, but there certainly are other physicians who are more experienced who do understand the importance of participating early in projects and are willing to do so. So those are the easy ones. But the change has to be outcome oriented, and you're looking for a better patient or system outcome that will impact the patients as well as the physicians, and typically that includes staff and other healthcare workers in that same environment as well. So looking for physician champions, sometimes they stand out, but other times they don't always come forward, but you know who they are in your organization. You know the people who are likely to get on board. That can be personality based, whatever it is. Think about the physicians in a specific area that you're looking to make changes, that you want to get involved, and think about who are the right people in terms of temperament, interest, likely to become an early adapter, and then get them involved. Listen to the concerns about potential problems in implementing your project, why they think it may be a problem, and then you have to support them. That can be time, which ideally would mean removing some duties, but it may require some money, benefits, educational activities, advancement, promotion, something that recognizes the time and effort that is put into that. That's an institutional choice, and all of you have different ways of rewarding and supporting people for doing that. Okay? And then finally, give them some authority to participate in the process so that they don't feel that they're just a bystander participant, but somebody who has true input into what the project might look like, what input they will have, to make changes in the future. And by doing that, you can ensure that you do have a physician champion who's happy to work with other people. And again, I mentioned the term personality because you want people who are team players, who are going to work with the other health professions involved in the project or with other staff members as well. Okay. Again, focus on a specific outcome of some type. You're not looking to just change a physician's behavior. You're not looking to make, quote, people communicate better. You're looking to improve a specific outcome. So when you're doing that, make sure that you're very, very specific in how you lay out that information and provide that information to not only the physicians, but in terms of others where you're looking to make a change in a project and you're looking to bring physicians on board. So what is it you're going to fix that will result in improved outcome? Examples might be in the ambulatory setting with shorter wait times, finishing on time, making sure the abnormal results are always received and acted upon. Inpatient, the obvious ones are eliminating central line infections, length of stay. The operating room, there actually are very nice examples from the published in teams using team steps of earlier start times, better use of equipment, fewer infections. And again, ideally, you want your data, so you have your data to confirm that you actually are making improvement in the outcomes. Now, what about training? So you want physicians to get involved. As I mentioned and gave you an example from the Keck School of Medicine, they provided training over 10 months for people. But so for leaders, you may require financial support for proper training. And for initiating the project, the training's got to be convenient. Is that going to be at 6 in the morning for those who are working in operating rooms? Time limited, ideally without cell phones. Huge issue for all of us, but some have actually done training with cell phones put in a basket on the side. Focus on limiting material. Don't overwhelm people. Look for things that will be directly relevant and will make their life better. If people feel there's something in it for it, they're more likely. Physicians are like that. And when you're doing training, be creative and be interesting. Don't come in with your set of PowerPoint slides for an hour and tell either a small group of physicians, large group of physicians, what your project is and how exciting it's going to be that you're rolling out. So you can be creative. You can use videos, using real case examples as example, including even your own institutional mistakes. Be open and honest. People will appreciate that. Limit lecturing. Use online delivery if you have to because of time constraints. And the goal is really to generate discussion and demonstrate value. And the value is we're going to improve the outcomes for our patients, and we can show how we're doing that, and we have data to support that. One of the areas that I find is very helpful is even just using videos, and you can use both medical and so-called non-medical videos. I will tell you from my personal experience with training over many years, one of the videos that I think demonstrates how important it is for leadership and for using very effective communication is the famous landing on the Hudson. And that video is readily available through YouTube. This is, as shown here on the screen, is the video that actually has the flight recorder with demonstrations of where the plane was. And I will tell you that everybody is fascinated with that. And you can almost always get physicians to watch that video and then have a discussion about how they communicated and what the leadership from Captain Sully and co-pilot Skiles did to ensure the safe landing of this plane on the Hudson. Other examples, including more humorous ones, such as the Whodunit, which is a very fun video to watch, which shows a characterization where there are a number of changes that occur, and it really gives people an opportunity to look at their observational skills. And it's one of these videos where you really have to watch it, and it's very short, very important. And equally as important are real stories. Here's a video called Silence Still Kills. It's a story of a nurse telling a story about a wrong site surgery, and it's a real story, and it talks about the OR and what was done, what wasn't done. Real story. Again, these are short videos. They're essentially trigger videos. They get physicians engaged when you're trying to do the actual training. And so what you're able to do is use a video that illustrates what you're trying to address or train people to do without having to overwhelm people with a large number of PowerPoint slides. So in summary, physician engagement and buy-in is a must if you're going to make changes. This is really one of the more important things you can do. Physicians are therefore essential for successful change, but you've got to find your champions, and they're out there. If you're not sure they are, look for them and you'll find them. Listen to physicians who are naysayers. There's a lot of times when there's a very good reason when your pet project is doomed to failure for a number of reasons that you haven't seen, which is normal, but you'll get the input from the physicians who will tell you why there's a problem, and many times you can engage some people who are naysayers to provide that information to improve your project and actually get them involved. Make patient safety a personal issue. For me, I try and remind everybody that all of us need our own healthcare, our families need healthcare, and we want the physicians and the healthcare providers that our families see to be following principles and practices that provide the best patient safety and the best outcomes for ourselves and our own families. And nobody wants to make mistakes. So this is all about improving patient safety, and then use the data from your own institution. So what are the key takeaways? We'll finish right here. Since physician engagement is essential, create a formal strategy. Stop and think about how to engage physicians when you're looking at QI projects, patient safety, and team training initiatives. Make sure your leadership is lined up all the way to the top. As I mentioned several times, this is one of the more important things. Focus on patient outcomes. Again, all of us want to see our patients do well. We want to see the best outcomes possible for our patients. Line up your physician champions, use real data. And by understanding the different barriers which we've talked about, do your best to eliminate or reduce them. These include time and money issues. Again, it doesn't have to be dollar for hour reimbursement, but recognize these are important in terms of some of the more important barriers to physician engagement. We've given you quite a list of them. And always ask, is there a good reason that if I was a physician, I would support your quality improvement initiative? So again, you have to look at it through the eyes of the physicians who are going to be potentially the ones involved in your projects or in your activities. So with that, I'm going to conclude. I'm going to leave some time for questions. I'm going to turn things back over to my colleagues at the American Hospital Association. And I hope this has been helpful to you. And again, physicians want to see good outcomes and they will get engaged, but you've got to follow a strategic process to do so.
Kevin, thank you so much for the presentation here. A lot of great insights. We've gotten several good questions as well. So I'll get started and we'll try and get through as many as we can here with the 10 or so minutes that we have remaining. Just a couple logistical items, just wanted to clear up. There are some questions around that. The recording will be made available to everyone within the next day or so, and the presentation as well. Kevin, we're getting a lot of questions on, hey, can we have links to those videos? So all that will be made available. So good questions around that. Let's get into some of the more discussion questions here, Kevin. We got a few around just different physician groups, different employment statuses. So how do you engage those physicians that are independent versus those that might be employed? A trend that we're seeing that we're all probably experiencing is a lot of these physicians, depending upon what part of the hospital they're working in, might be entirely independent or working for another. Their employer might be somebody else entirely, whether it's the ED docs or elsewhere. So any recommendations on how to get those physicians engaged? Some of them might be there for a couple months or a couple days out of the month, or some might be working at multiple sites across different health systems. So any advice around that, Kevin?
Oh, certainly. So I'm going to assume that people are talking about doing some type of project, whatever it is, wherever it is, that's aimed at quality improvement to improve patient safety. So first of all, one of the challenges that you may never get 100% of physicians engaged, okay? but you can get a significant number. But the key is by focusing on what I said very last. Physicians want to see good outcomes for their patients. So it has to be completely patient-centric, not what the hospital wants, what the clinic wants to do, what the employer wants, but focus on something that a physician would see as meaningful in terms of improving a patient outcome, without feeling that we are going to participate in an activity where some type of outcome, and it doesn't have to be drastic, it can be something simple in an outpatient setting. That's actually what I would say is one of the key things, because if that's the case, then it doesn't matter whether somebody's employed or not employed. And then what you need is a core group of at least people who are modeling whatever the appropriate behavior is to achieve that outcome. And then you have to bring those in who are not there on a regular basis. It's a real challenge for people who are participating on a limited basis. It's sort of like those of us who go to certain hospitals on a limited basis. When you use their electronic medical record, it's really hard if you're only there every 3 months. Same thing with physicians who come in for very short periods of time. But the physicians who are based in settings, if your project and your activities are going to be focused on patients and their outcomes can be demonstrated and the leadership's lined up, those are going to provide you your best opportunity for success.
Thanks, Kevin. A good transition to the next question is on EHR and EHR reporting that we have one here. So question is, how do you respond to this quote that you might get? I document everything. It's the EHR reporting that's not working. And this person will respond by saying, hey, quality measure data has to be entered discreetly, differently for EHR reporting to work. But the question is here, how do you respond to that when some providers just aren't budging on that?
One is the challenge of the EMR, and we all know that many physicians, myself included, at times feel, why am I doing this? This is a lot of work and I'm not sure what I'm getting out of it. So that's a real problem. But this is what I say. So on July 1st, I will actually be going back on the hospital service as a nephrologist. And what I do on day one is I tell my team that whether you like the electronic medical record we use, and nobody likes whatever they use, but that doesn't matter. Whether you like it or don't like it, at the end of the day, you can never use the EMR as an excuse for poor patient care. Patients expect the best and patients deserve the best. So our job is to provide the best care, sometimes in spite of the EMR. So you really have to have that mentality, because at the end of the day, if, as I said at the very end, making it personal, if I was a patient, I wouldn't want to hear there was a problem because it was the EMR that created the problem. We all know that it's about the physicians and the healthcare providers. So you have to use that mentality, difficult as it is, and get that mantra across that our job is to provide the best care regardless. If the problem is the EMR, then that's a separate issue between physicians and the institution. But at the end of the day, the patients still deserve the best care and hopefully the best outcomes.
Yeah, thank you for that, Kevin. Question on training in terms of with schools. Are there instances of where you've seen team stats training at the GME level or even at the med school level?
Yeah, I won't comment at the GME level because I'm not familiar, though certainly there are institutions that are doing team steps, so I can't give you specifics. But I will tell you that a number of years ago, myself and a colleague from the University of Minnesota, who's also been very involved in quality improvement, Karen Baum, we did a survey of medical schools in terms of what they were doing for team training. And at the time, most schools were doing some type of undergraduate medical education, interprofessional education, team training for safety. And the number one system at that time, which was really about 5 or 6 years ago, was team steps. I think more and more institutions are using team steps because it's a defined curricula. It's easy to use in an interprofessional basis, easy, I think, for our students to use. And we certainly use that at Tulane when we do activities that we have lined up with a local nursing school as well. So at the undergraduate medical education level, team steps and team training in general is becoming more and more common. And the question is, can we push this through the entire system so more and more healthcare professionals of all backgrounds are exposed to this in their training and expect to see it in their professional environments when they finish all their training.
So thank you. Question about the pandemic. So we're most of us, many of us, all of us are still very much dealing with it in some form or fashion. So any kind of innovative, practical strategies to engage physicians during the pandemic?
Great question. I think probably, and I alluded to it, is that, burnout is such a big issue, and the decision by some healthcare personnel of a variety of backgrounds to not continue in their professions has been a significant problem and significant blow to all of us. So what I would say is, in the process of engaging physicians, when you look at the burnout issue, then it becomes really, really important to consider, do they have time to participate in the activity? Are we compensating them? I'll use that as a global term, not just pure dollars, but are we compensating them for their time and effort? And we're not just further burning out physicians or other healthcare workers at a time when it's become very, very difficult for so many people. So I think the burnout issue, I would add that question into what you're trying to evaluate in terms of how to get physicians engaged if you're particularly concerned about the pandemic issues that have arisen.
There was a question, you had mentioned quality contracts at one point. Can you expand on what you mean by that and what those might include?
Well, it's really sort of a catch-all term, so I'm not going to say that it's one specific, but the goal is to come up with a specific plan for quality improvement activities where it's agreed upon by the different parties. So you can have, again, a consistent approach to the type of care that you're delivering.
I'm looking at the time here. We probably have time for a couple more questions. So there was one on interfacing activities. Peer review and quality activities. Can those be interfaced together effectively?
I think I'm not quite sure I'm understanding the question, but I'll try to answer. In terms of doing quality improvement with peers. I'm sorry, I'm just not quite sure.
Sorry, yeah, that's all I have. But we can move on instead of trying to guess what the question is. There are a couple other good ones here. There's one about training nurses and providers. How do you feel about that being done simultaneously? Given they're two different audiences, two different stakeholders.
I actually have a very, very strong opinion about that. And if you do not do your training in a multidisciplinary, interprofessional manner, then you're not doing effective training. So the only way to train is to put doctors, nurses, and in fact, everyone together in the room, whether it's therapists, dietitians, pharmacy, whoever it is. If you're going to do training, make sure the language is a common language, everyone hears the same message, and that they know that it ideally is supported at the highest levels of the institution.
Kevin, thank you so much. Looking at the time, we'll wrap up here now. Really appreciate your time and insights. Really impactful presentation here over the last hour. Just a couple final reminders for everyone. As you can see on the screen, you'll get an evaluation that pops up right when we wrap up here. If you can provide your open and honest feedback, that'd be helpful for us, helpful for Kevin, as we continue to want to do a better job for you all. And then a final reminder, just on the continuing education, create that Duke account, and then you have 24 hours to get get registered and file for your continuing education credit. Do reach out to us, any of us here at the AHA team, any questions or comments, and we look forward to seeing you all at the next one. Have a great rest of your Wednesday. Thank you, everyone.